Hello, and welcome to our presentation, Age is Just a Number, brought to you by BreastLink. This evening's discussion will focus on breast cancer and risk factors for this disease. Presenting this evening are Doctors Jason McKellop and Shawndeep Tang. In addition to our presenting physicians, we will be joined by Dr. Lauren DeStefano during the Q&A portion of this webinar. I'm Stephanie Landon from BreastLink, and I'm thrilled to be your moderator for what is sure to be an exciting and informative discussion. Before we get started, I just want to mention that we're going to hold all questions until the end of both doctors' presentations. If you'd like to ask a question, you can either type it into the chat box and I will read it to the appropriate doctor, or you can click the icon at the bottom of your Zoom screen to virtually raise your hand so that you can ask your question yourself. If you have any issues or technical questions at any point, please feel free to message me. Now, I'd like to introduce our first presenter, Dr. Jason McKellop. Dr. McKellop is a board-certified radiologist with fellowship training in breast imaging from New York University Langone Medical Center, and he's also the medical director at BreastLink Tarzana. He has said that the culmination of his life work has been dedicated to finding small breast cancers before they grow and spread and become deadly. So I'd like to welcome Dr. McKellop now.
All right, well, thank you so much, Stephanie, for that kind introduction. Again, my name is Jason McKellop. I'm the medical director of breast imaging with BreastLink and Beverly Radiology Medical Group here in Southern California. And the topic of my discussion today is going to be mammography, facing current challenges with new technology. And I'll basically just be providing a brief overview of how we perform screening mammography and some of the challenges that we face, and review some of the importance behind the epidemiology of breast cancer. And I hope you enjoy this talk and find it useful. So before I begin, I must first disclose that I am a consultant for Hologic, which is a medical technology company. And the objectives of my talk today is to first review some of the statistics underlying breast cancer, as well as screening mammography as an imaging modality. I would also like to review or discuss the state of the art as it relates to the technology underlying screening mammography, namely digital breast tomosynthesis, which is commonly referred to as 3D mammography. Next, I'd like to discuss some of the challenges that are facing mammography and perhaps radiology at large. And finally, I'd like to discuss the newest advances in radiologic interpretation, which is the involvement of artificial intelligence. So before I begin, I just want to review some of the background behind breast cancer as a disease process. So we'll review some of the stats or epidemiology of the disease. And we know that excluding cancers of the skin, breast cancer is the most commonly diagnosed cancer among women. It's the second most common cause of cancer-related mortality, or in other words, deaths related to a disease process. And regardless of how many times I see this statistic, it never ceases to give me pause. But 1 in 8 women, or roughly 12% of women, will be diagnosed with breast cancer in their lifetime. And if you think about this, all of us know at least 8 women in our lives. So it's no surprise that this disease hits close to home for all of us. Just thinking that 1 in 8 of these women may develop the disease in their lifetime. And finally, of those women who are diagnosed with breast cancer, 1 in 3 such women will die from the disease. And I apologize for these sobering statistics, but I hope this ultimately gives some weight or gravity to the importance of the disease process and the work needed to diagnose and treat it. Frustratingly, the incidence of breast cancer is slowly increasing. Incidence is basically defined as the rate at which a population is developing a disease. So we've seen over the past several decades, there's been a slow incremental increase in the rate at which breast cancer is being diagnosed. Fortunately, however, the deaths related to breast cancer are slowly decreasing. And this is felt largely to be attributed to the fact that we're able to diagnose disease at a smaller size, and that the treatments for this disease have improved. Interestingly, the rates of breast cancer among certain ethnic populations are higher than others. But the mortality or deaths related to the disease are often unrelated to the number of cases in each population. For example, when we look at the rates of breast cancer among American women, we can see that the highest rates of breast cancer are among white non-Hispanic women. However, if you look at the rates of death that are associated with breast cancer, these rates or mortality rates are highest among Black or non-Hispanic women. And the reason for this discrepancy are multifold and probably beyond the scope of this discussion, but it's an interesting thing to note when looking at the epidemiology of the disease. We also know that the risk of getting the disease generally increases with age, and that the average age of diagnosis for breast cancer is somewhere in the mid-60s, approximately at age 64. When we look at the entire population, somewhere in the mid-60s, the disease is typically diagnosed. So, having reviewed some of that statistical data behind breast cancer epidemiology and some of its background, let's take a look at the technology that currently exists to actually diagnose the condition. And this is primarily through screening mammography. And this is a cartoon that's showing a 3D mammogram, or how a 3D mammogram is captured. At the bottom of the image, you can see the breast being compressed between a compression paddle and the detector. This is a part of the equipment that receives the X-ray energy. Some patients ask, why is there such a need to squeeze the breast in this fashion? And why do we need to apply so much pressure to get the image? Well, the answer to that is twofold, really. First, it helps to spread the tissue out so that we can see the anatomy in better detail. And secondly, compression helps prevent motion, which can cause artifact or blur in our image, which can make things more difficult to see on our radiology images. And sometimes that can make the image entirely uninterpretable. So how does this work? The X-ray tube slowly swings along an arc above the breast, and it emits a low dose of radiation, exposing the breast tissue to this detector. And having done that, sending these low dose radiation images, we can generate a three-dimensional image of the breast, similar in concept to a CT scan. And this allows radiologists to scan through the breast progressively and interpret scans more accurately and with greater confidence. Greater confidence that the findings within the breast are either truly present or truly absent. And we'll get into this idea here on a subsequent slide. So this is the resultant image from the tomosynthesis. I don't know if this will play, but this is a resultant image once we capture those low dose radiation exposures that I demonstrated on the previous slide. And it essentially creates a stack of images that you can see here in the middle of this slide. And we can do some really interesting things with this. First of all, we can generate the conventional 2D image, which you can see here, which is like a flat sheet of paper. That's how things were done conventionally up until 5 or 10 years ago. And 2D mammography still remains a standard of care, but 3D imaging, the stack of images, allows us, like I had said, to interpret studies more confidently, because it allows us to basically scan through the anatomy as we would a CT scan or a breast MRI. All right, so what are some of the challenges that are facing mammography currently? First, we know that mammograms are not 100% sensitive for detecting breast cancers. Therefore, mammograms are not infrequently plagued by false negatives, meaning a cancer may be present on an exam, but not visible on the mammogram. And this is either the result of a misinterpretation or oversight by the interpreter, or the disease truly being mammographically or occult, or we're just simply not able to see it on a mammogram. Also, mammograms are not 100% specific for detecting breast cancers, meaning exams are frequently plagued by false positives, where some findings that are normal or benign may resemble cancers on a radiograph or on an X-ray. And getting back to this point or this question, why is so much compression necessary for the exam? Why does the exam have to be performed, with such, technical detail? And that's because one of the biggest challenges in interpreting a mammogram are these kind of false positives. So if we ever get superimposition of tissue, meaning if you can imagine scrolling through those slices that I'd shown on the previous PowerPoint slide, scrolling through that stack of images, and you have breast tissue, especially dense breast tissue that overlaps itself, it may create false findings or may create the impression that there's a mass or something nefarious going on when there truly isn't a finding there. So it is critical that we perform these exams holding strict accountability for technical adequacy and so forth, such that we can get a precise image of the breast. Another challenge, finally, is that human beings are not perfect. We're prone to distraction, fatigue, and we possess countless other flaws that may limit our ability to interpret mammograms. So, over the past couple of years, we've noticed, an explosion, if you will, of technology that surrounds artificial intelligence. So I do want to dive into the future of mammography just briefly, because the future is somewhat present here within our company at RadNet, and I'll get into that here shortly. But the future of mammography and maybe medicine at large truly lies within artificial intelligence. And I want to talk about that here briefly. So over the past couple of years, like I mentioned, there's been an explosion of new technologies that have taken advantage of artificial intelligence. Some of them we have seen in the news have not been without controversy. Take Tesla, for instance. This is a car manufacturer that all of us know has taken on the challenge of developing a self-driving car or autonomous self-driving using effectively artificial intelligence technology. This is no easy task, of course, because all of us have seen in the news there have been accidents that have claimed countless lives. More recently, we've seen ChatGPT, which has developed a large language model that can not only have conversations as a human being would, but can also write term papers, take medical board exams, it's passed the bar exam with flying colors, can also do very convenient things for all of us, like create travel itineraries in a matter of seconds. So we're only really scratching the surface of what these technologies have to offer. A lot of us have smartphones with Siri capability. For instance, we ask Siri to turn on our lights or answer questions, and that's basically the most rudimentary form of artificial intelligence that we know. But it also does have application to radiology. Given the constraints, of medical imaging, some of which I've reviewed, and the countless shortcomings of human beings, it should come as no surprise that mammography has been in the crosshairs and a leading target for artificial intelligence research over the past several years, if not decades. And I feel particularly privileged to be discussing this topic because of the incredible opportunity that I've had over the past year to actually incorporate some of this technology in my workflow and to use artificial intelligence in my daily practice as a breast imager. So around 3 years ago, RadNet acquired an artificial intelligence and machine learning company known as Deep Health. And they've developed several AI products, one of which I'll mention briefly, called Sage DX, which gives us the ability as radiologists to essentially categorize cases into high, intermediate, and low and minimal suspicious lesions. And that confers several advantages for us as radiologists. Basically, when we encounter our work lists on a daily basis, the first thing that this affords us is the ability to sort the cases in order of not necessarily importance, but risk stratification. So if I come in the morning and my mind is fresh, I'm able to, tackle the more challenging cases, or the cases that this artificial intelligence software has deemed to be a high risk case, so that I could dictate these cases in a timely manner, get them out to the referring clinicians, and have patients have their diagnoses, especially these critical ones that are at high risk of being disease, out in a timely manner. So it's helpful in that regard in terms of sorting cases, but it's also helpful in terms of our interpretation of each case on an individual basis. So what the software does is effectively draws regions of interest, or big squares, if you will, or circles around lesions that the software deems to be of a varied risk stratification. And it can do this fairly well. In the high risk stratification, for instance, there's nearly an 80% probability that there's a finding of significance on the study. And that gives the interpreting radiologist a sense of confidence when interpreting the study, and in so doing, more confidently calling back studies that need to be called back, and more confidently ignoring findings that don't need to be called back. So as I mentioned, artificial intelligence can help us highlight suspicious lesions on mammograms. It can improve practice efficiency by helping us sort our work lists, and it can also assist in scheduling and staffing patients. It's a very nuanced and sophisticated software. And again, we're only scratching the surface of this new technology, but it confers several advantages. And even though the question may arise about job security, whether or not this is threatening my own job as a radiologist, I don't feel that that's the case. I feel that artificial intelligence is here to help in this setting, and more globally speaking, here to help humanity, and not necessarily to hurt us, or at least as it relates to radiology. So as I mentioned, we've already begun to implement artificial intelligence into our daily workflow. We've already had artificial intelligence to some degree baked into our platform when we do acquire those images. As I demonstrated on a prior slide, artificial intelligence is already compressing and processing those images before it even meets our eyes to show us the most salient findings. So that's already kind of baked into our process. And as I had alluded to earlier, it can help us confirm that a study is truly negative. We do not like calling patients back from screening mammograms. Yes, it's a necessary evil, but we do not like to do it. And we'd like to reduce the number of callbacks as much as we can, while safely diagnosing disease as accurately as we can. And this artificial intelligence algorithm also helps us to reduce that callback rate. So several advantages with artificial intelligence. So in conclusion, we know that breast cancer is an important and prevalent disease process. Mammography is evolving. The way we diagnose disease is evolving, and that evolution in of itself creates new challenges. And fortunately, artificial intelligence is here to help, and here to help us overcome some of these challenges. I hope this has been a useful talk, and that concludes my brief discussion, and I welcome any questions.
Thank you, Dr. McKellop. Dr. Shandeep Tung is our next presenter. He is a breast surgical oncologist for BreastLink at Memorial Care in Orange County. He received fellowship training at Georgetown University Hospital in Washington, D.C., and he has an extensive list of publication and presentation credits. Dr. Tung.
Good evening, everyone. My name is Dr. Shandeep Singh Ung, and first and foremost, I want to thank you all for taking the time out tonight to join us here for this talk. Also, I would like to thank my colleagues who are on the panel for joining us tonight too. So let's go ahead and get started with my part of the presentation. Okay, so a question I get asked a lot by women is, when should a woman be evaluated for breast cancer risk? And what I generally tell patients is, if they are at the age of 25 or older, they should be evaluated by a breast surgeon or another appropriate clinician who can do an appropriate breast exam. That's the most important start, is to first get familiarized with not only your own breasts, but a clinician who can also do exams and be able to discern if there are any concerning lesions there, number one. Number two, being able to ascertain a clear family history will help with the risk estimation. So before you meet those providers, it's important for you to actually understand what your family tree looks like. So when those questions are asked, you can readily answer them. And the reason why it's so important to get this screening done early, because there are some guidelines for appropriate patients where screening can begin as soon as 25, and that's screening with imaging, not just breast exam. And when you do meet these clinicians, as I do in my own practice, I always use a risk assessment model to determine the personal risk. And that's something that I will go over in a little bit. Okay, so as I mentioned, risk estimation, there are models out there and there's calculators that we can use to enter information about A, the patient, and B, the patient's family history, and also their personal history in regards to biopsies and things like that. The Tyrer-Cuzick model, it uses the IBIS calculator. This is my preferred tool. This is what I use for all my patients. IBIS stands for International Breast Cancer Intervention Study. I do have an example on the next slide, which I'll show you, but this basically estimates the 10-year and lifetime risk for patients getting, for a patient to get breast cancer. And this calculates it up to age 85. So basically, whatever age you test the patient at, it'll give you a graph that shows your risk in a graphical representation versus the general population, and then also percentage risk of getting a breast cancer from that age to age 85, as well as a 10-year cancer risk. Another thing that I like about it is also gives an estimation for your BRCA mutation carrier status. So for patients who haven't had genetic testing or curious about it, this tool can also help us kind of determine what your risk of being positive for that mutation carrier may be. Another thing I love about this this model is that it has a lot of data points, including breast density. So breast density is very important for women to understand in regards to mammography. The more dense the breast is, sometimes the more difficult it can be to discern small lesions on mammography. And being able to enter that into a risk calculator, we can determine the patients that may be at higher risk because of that breast density. So on this slide is a screenshot of the calculator with nothing filled out there. So basically, as you can see, there's a whole bunch of data points here, and a lot of those boxes actually have further trees of data that you can enter. So as you can see, and as we all know, the more data, the better. It gives us more information to kind of help that specific patient. So I really like this in regards to all the very specific data that it asks about the patient. As I mentioned, that the Tyrer-Cuzick model, the IBIS calculator, that's the calculator and model that I prefer to use. However, there are other models that are commonly used. The Gale model is probably one that's more commonly used outside of the Tyrer-Cuzick model, also known as the Breast Cancer Risk Assessment Tool, or BCRAT. This is similar to Tyrer-Cuzick. However, it estimates a shorter term risk. It estimates the 5-year risk as well as the lifetime risk. Their lifetime risk calculates out to age 90, so a little bit longer there. However, patients who have high risk features, such as maybe a previous biopsy or strong family history, the Gale model is not as accurate as predicting that lifetime risk. Otherwise, for patients who are at average risk, the Gale model is pretty much similar. It does not estimate the BRCA mutation risk, so that's another limitation that I don't like. And I also really don't like that it doesn't have as many data points as the Tyrer-Cuzick model. I think it's only about 7 data points that the Gale model uses. And I like to have more data points. It's something that I find more reassuring with the assessment, or I should say with the risk assessment number that it gives you. And for different risk models is a different number. Generally speaking, when a patient has a risk of 20% or greater, we consider them high risk, and that would be in the Tyrer-Cuzick model. In the Gale model, the number is actually closer to 1.67%. And that's a little bit too much detail for now, but certainly something that we could go into more at the end when we do our question and answer session. So I just include another couple models here, the Klaus model, Floor model. There's a bunch of different models. We don't have enough time to get into all of those. But one thing that I did want to note is that all these models have limitations, especially in minority populations. So it's important to kind of take that into consideration when you're evaluating your patients, or I should say when we are evaluating our patients. So once you know your breast cancer risk, then so what, right? What next? So there are several different screening guidelines for patients. I tend to follow the recommendations of the American Society of Breast Surgeons. That's the national body that are basically our mentors or our, thought leaders. But as you see, I listed there a few other ones: the United States Preventative Services Task Force, American College of Radiology, American Cancer Society, etc. They all have their own recommendations, and we'll go into some of that now. So, So what are some of the screening guidelines? Well, just to start off with the average risk for women, 1 in 8 women is considered the average risk. And that number, however, is going to change. You're not going to be 1 in 8 when you're 30, and you're not going to be 1 in 8 when you're 80. So that risk is actually going to be slightly lower earlier on, and the risk grows over time. The reason we use that 1 in 8 is when we average it out over time. That's about your risk. So we'll consider that the average risk patient. And those average risk patients, as I mentioned earlier, they should have some sort of clinical breast exam starting at age 25 and yearly mammography beginning at age 40. And then it should be every year. Now, not all institutions have 3D mammography. Our breast link facilities do, and that should be used when available, also known as tomosynthesis. So what about those women that I discussed that are at higher risk? So high risk is based on the risk assessment models, as I described earlier. 20% for most, certainly with the Tyrer-Cuzick model, if a patient is a lifetime risk of greater than 20%, I consider them high risk. And I initiate a high risk protocol, which I'll talk about in a second. And as I noted there, it's a different number for Gale. People who didn't necessarily have that risk assessment but have a gene mutation carrier are obviously going to be at higher risk, as well as those with strong family histories. And specifically women who may have had chest mantle radiation between the age of 10 and 30, that's another patient population that we want to be certain that we're screening at a higher risk. So what's the difference between those high risk patients? Well, one of the main differences is we're going to increase the screening with more imaging. Annual mammography is still recommended. However, also annual MRI is something that's also considered. I tend to stagger those 6 months apart. So my patients will have something twice a year instead of bunching them together. Now, another point to mention is in patients who have family relatives with breast cancer at younger ages, less than 50, that's when we start to think about screening patients earlier than age 40. So generally speaking, annual mammogram and then again MRI, where available, we should start screening patients 10 years prior to when the youngest family member was diagnosed with breast cancer. Now, for mammography, we don't want to start before the age of 30. And for MRI, we can go down to as early as 25. Now, mammography is less sensitive in patients with denser breast tissue, and the younger the woman is, the more dense that breast tissue becomes. And but in both cases, the mammography should not begin later than age 40. And I do notice there's a typo there, sorry for that. And again, for high-risk patients, a minimum of every year, they should have a breast exam. However, I recommend to my patients having a clinical breast exam every 6 months. And generally, I try to coincide that around the time of their imaging. So something that's been out in the news recently is that the USPSTF, the United States Preventative Services Task Force, previously actually recommended women to have mammograms at age 50. And they recently lowered those recommendations to be more in line with the rest of the guidelines that are from those organizations that I mentioned before, such as the ACR, the ACS, and especially the American Society of Breast Surgeons. So that's a positive, because that's something that will open up more insurance carriers to covering these mammals that women are having earlier. So another question that I commonly get is, when do we stop screening? I have a lot of patients who have primary care physicians who essentially, after the age of 70 or after the age of 75, tell the patients that they don't necessarily need imaging. Now, that is that's a bit of a sticky situation, because nowadays women are living longer, and the thought process is that if a woman has a life expectancy of greater than 10 years, then certainly we should consider screening them for any breast cancers. The USPSTF, based on prior randomized trials, as I noted there, that data stopped at age 74. So excluded data from women that were over the age of 75. So basically they had no recommendation for patients over the age of 75. So I think that's kind of where it stems from. However, for my patients, those who are willing to continue screening, those are patients that I will continue to screen. I've had patients who stopped screening mammography at age 70 because the physician told them that they didn't necessarily need it or weren't necessarily at high risk for breast cancer. And this is a patient who came back to me at the age of 78 with a palpable invasive cancer. Luckily, it was the low-grade, slow-growing cancer, but she came to me with a lump when potentially we could have found that on screening mammography much sooner. Now, would that have been something that could have caused a survival issue for her? Maybe, maybe not. But certainly in 10 years, breast cancer can do a fair deal of damage. I would argue that if the life expectancy is at least 5 years, I would encourage continued screening. But most importantly, it's the patient motivation. Some patients do or do not want to do further imaging, and that's something that's important to weigh when we discuss continued screening for our elderly patients. Another common question I get for patients who are diagnosed in their 80s, maybe even 90s, am I too old for surgery? So that's really an important question. All patients are different in their life expectancy, their health metrics, their overall physical well-being, and even just their own preference. So individual care plans are essential for all patients, but especially for those elderly patients who may not tolerate surgery. So that's something I'll look at is what is their comorbidity status? Is their cancer hormone receptor positive? What are some of the other options that we can choose if the patient declines surgery or if the patient is unhealthy for surgery? So as long as the patient is motivated to move forward with surgery, and I think that the patient will tolerate the surgery, there's no upper age where I would say no. But I certainly would have the discussion of other options if there were. And those are options that we would discuss in conjunction with the multidisciplinary team, including the medical oncologist and the radiation oncologist. So again, that last line there, some patients will decline surgery and want to know if there's any other medications that they can take, and that may be appropriate in selected patients. Thank you for your time, everyone. There are references available upon request if anyone's interested. We will have a Q&A later on, so please stick around, and if anyone does have any questions, I'll be happy to answer them.
Thank you, Dr. McKillop and Dr. Chung. Before we get to questions, I would like to introduce our special guest who will be joining us. Unfortunately, Dr. Del Rosario is unable to be with us due to an unforeseen situation. However, we have Dr. Lauren DeStefano, who is a breast surgical oncologist at Cedars-Sinai. Thank you, Dr. DeStefano, for joining us. So now we're going to get to some questions, and I'm going to start with reading questions that have been typed into the chat. And if you have any while we're going through them, please feel free to type them or raise your hand. So the first question I have, does having IVF, however many rounds, increase your risk of getting breast cancer? Who would like to take that?
So I'll try to take a stab at it, for lack of a better word. I'm frequently asked, maybe not as frequently as my surgery colleagues, about risk factors for developing breast cancer. And risk factors for the disease are multifold. It's a complicated discussion. There's some hard and fast risk factors such as age, female gender, for instance. But there are other more obscure risk factors like alcohol intake, obesity, some things that are not necessarily linearly or very clearly associated with developing the disease. When I try to conceptualize or think about risk factors, one large categorization or umbrella would be hormone exposure or estrogen exposure. The reason that you're asked such questions on a survey or questionnaire when you come into our clinic, such as, how many pregnancies have you had? At what age did you develop pregnancy? Did you breastfeed? It's because all of these questions contribute to estrogen exposure. If you've never been pregnant, that means that you would have gone through a monthly cycle of your menstrual cycle, that much longer than someone who was pregnant for 9 months and essentially went without estrogen exposure for those 9 months of cycling. So estrogen exposure is, one contributor to developing the disease, because you do have estrogen sensitive tumors. So if you looked globally, and getting back to the original question about IVF, if you're exposed to some estrogen for harvesting eggs, for instance, then yes, there would be a slight increase in some women by getting IVF in developing breast cancer. And when we do say increase, we're looking at a global and kind of bird's eye view of the population. So even though the risk may be increased, it may just be a slight increase. Whereas we detect 6 in 1,000 patients with breast cancer, there may be 7 in 1,000. I don't know the numbers specifically, but I would anticipate there would be a slight increase in risk for developing the disease secondary to that hormonal exposure.
So is that also true for other fertility drugs?
If there's hormone involved, I would suspect yes, that the breast as well as the ovaries and uterus are hormone sensitive tissue, and any stimulation of that tissue stimulates cell turnover, and cell turnover has genetic divisions or separations and division and multiplication, and those genetic divisions can propagate mutations, and that's really the underlying etiology of cancer development.
Okay, so
I'm going to echo. I'm sorry. I'm going to jump in. I'm going to sort of echo what Dr. McKillop said. I get this question a lot, actually, in terms of hormone replacement for similar sort of things. And what I always tell patients is a risk benefit, right? Our data is not great on hormone use and how much does it increase your cancer risk. Our best studies come from prospective randomized trials, right? We take a group of people, we divide them into 2, and we see what happens. Sort of not ethical, right? We can't divide the population and give half the population hormones and say, like, do you get cancer? So our studies are mostly retrospective survey-based studies, which are inherently terrible studies, right? Who remembers what they took, how long they took, what the dosage was? And the hormones in those studies were different than what we use now. So could it potentially increase your risk? Yeah, maybe a little, but it's a risk benefit, right? So for the postmenopausal woman who's asking about hormones, if it's someone who everybody in their family had breast cancer at age 30 and they have no postmenopausal symptoms, well, probably not worth the added risk, right? But if you have no family history, you're sort of an average risk patient and you're miserable, right? Your quality of life is terrible. It's probably worth taking the hormones, right? So it's probably very similar for IVF, right? Your desire to have a baby is outweighing that slight risk that you would potentially have from increased cancer.
The follow-up to that is for someone who has, taken fertility or postmenopausal medication or IVF, would that change their guidelines for having mammograms or other screening?
So I also use the Tyrer-Cuzick model that was described, and in there you can put in hormone use and length. And I've done this with some patients where we sort of play with it. If I stop hormones today, does it change my risk? Or if I go on hormones and use it for 6 years, does it change my risk? And it really doesn't change it that much. So for a patient who's had IVF, if they're otherwise the sort of average risk patient, I personally would not increase screening on that patient.
And if a person, does IVF and then they get pregnant, does the pregnancy reduce the breast cancer risk?
Potentially.
Right. Okay. Thank you. Another question. I believe this is for you, Dr. McKillop. when you were mentioning the increase in breast cancer over the years. Is this something that's being seen in all countries, or is the US leading the world in this statistic?
That data is primarily from the US population, but I do believe, and maybe my colleagues can correct me if I'm wrong, that in the majority of the Western world, that uptick in breast cancer rate is being observed, and is probably true globally as well. In parts of the world, we don't have as reliable data as we do here in the West and in the US specifically. So it may be a hard question to answer absolutely, but it's certainly true of the US.
Do you think that's because we have better screening now, or other environmental factors, or?
That certainly contributes to it. We have better means of detecting cancer, so the fact that we're diagnosing it can contribute to it. But these studies also control for our ability to detect the disease, and regardless of our ability to detect it is improving, certainly as technology improves, the rates are still going up when you control for our ability to detect the disease as well. In terms of what environmental factors, we can all speculate, but we can't really point a finger to a specific thing. And I'm sure, just like everything in medicine, it's a multifactorial thing that's contributing to the steadily increasing risk.
I have some raised hands. Okay, so I have some raised hands. Let me find what those are. Sorry, sorry about that. All right, in the meantime, while I find the raised hands, let me read you this other question. Do you recommend taking hormone medication instead of having a thyroid removed?
I guess I'm a little confused on the question. Thyroid hormones would not influence breast cancer risk from my understanding. So can someone clarify the question?
Yeah, can you clarify that, please? Okay, we'll wait for clarification on that. In the meantime, I'll ask you another question. If I were to test negative for a genetic mutation, but I still have a strong family history, am I still considered high risk?
That's a great question, and I see a lot of patients in this category. I think first thing would be to run the Tyrer-Cuzick, because I think regardless of genetics, you can still be over that 20% risk, and then I would consider you high risk. I often sometimes have patients who have very strong family history, not just mom, but mom, grandma, aunt, lots of women in their family have had a breast cancer, genetically negative, but their risk may not be over that 20%. I still sort of would consider them high risk. I think sometimes we just don't know all the genes. I think it's a discussion, right? How risk adverse are they? How are they willing to do the increased screening? I often do the every 6-month interval, like was described. So the yearly mammogram, the yearly MRI, staggered at 6-month intervals.
Okay, sort of connected to that, another question I have is, I am in my 20s and my mother had breast cancer at age 40. What would the recommendation for me be?
Like, I can take that, unless Sean, you're diving in there, but we recommend that all women at average risk begin at age 40, unless in this particular circumstance, where a first-degree relative has been diagnosed, in this case at age 40, we'd recommend 10 years prior to the nearest first-degree relative. So in this patient's case, it would be starting at age 30.
With screening. Okay.
And I will just jump real quick, if you guys can hear me. Sorry, I was having a bit of a technical issue there. So yeah, I totally agree with those screening guidelines. And quickly, just about the IVF and hormones, just as Dr. DeStefano, I was saying, a lot of it has to do with the risk-benefit ratio. So just, I totally agree with that. And it for those high-risk patients that may not be may not have genetic mutations, may have you know, a very suspicious family history. Sometimes they'll get a score that is kind of surprisingly low. Those are patients that I'll give them the option. You know, maybe they're not someone who would qualify for MRI, but I'll offer them screening breast ultrasounds instead, which offer no radiation. So patients really like that option. And then especially in those women who have dense breast tissue, that's another great option to have. You know, another imaging modality that doesn't have the same limitation in regards to breast density as mammography may have.
Here's another question. Is there any change in and factors associated with the small incidence of breast cancer and its varieties that are found in male breast cancer? So I guess incidence and varieties of male breast cancer. Has that number gone up?
You know, I don't think the number has changed significantly. I'm not exactly sure about the number. Maybe I'll defer to my panelists. But one comment I will make about male breast cancer is I think one of the biggest problems is that, well, first let me rewind there. Male breast cancer is essentially the same as female breast cancer. The prognosis is the same. The problem that we have is that men tend to present later. We don't, for the most part, assume that a lump in our breast is going to be a breast cancer. And quite frankly, the opposite is true. So that's one point I'd like to make. If you know a male who has a lump in their breast, regardless of what they may think, it should be evaluated as quickly as possible.
Can men be considered high risk just as women can?
So I agree with what was said. I think the number is 1 in 866 in men, if I remember correctly. So very different than women, but I agree. They're stage for stage, they have the same prognosis, but like was said, they do present at a later stage typically because men don't think that they can develop it when they in fact can. And men can be high risk. Yeah, you know, they can have genetic mutations just like women can.
So if a man has a mother who had breast cancer, then is that something that they should, you know, talk about with their physician? Or
that's a pretty good question, actually. That's, you know, I think in that scenario, I don't think that, you know, again, 1 in 866 is a pretty good number, and it's a low number when you compare it to that 1 in 8. So would I recommend any kind of screening for those patients? No, but if you know, if you had a strong family history for breast cancer and you're a male, well, is there any BRCA in the family? That might be something that you'd be interested in, because that would certainly be a problem for you as a male. But I would just tell those patients to be hyper vigilant about lumps in your breast. If there's anything going on, don't wait, and then definitely see your primary care doctor, mention the family history, and then certainly you would get breast imaging just like a woman.
okay.
And correct me if I'm wrong, I don't think there's any guidelines for screening for breast cancer in men, even in BRCA positive. I think it's just being hyper vigilant, like was said.
That's correct. There is no screening paradigm for men, which, you know, as Dr. Tung pointed out earlier, is one of the reasons that men present typically at a later stage. They present with a palpable lump usually. So in those cases, absolutely, getting, you know, physical exams on a yearly basis and self exams have that much more importance.
So someone asked if you could elaborate on how my genetic test results are used for my imaging.
So I can take a stab at this one as well. So those genetic test results will confer a risk stratification. As was pointed out earlier, the average risk is about 12%, and this is a lifetime risk of developing breast cancer. The intermediate risk stratification is between 15% and 20%, and then a high risk stratification would be 20% or above. There are genetic mutations from that genetic testing that can confer a risk of developing the disease of greater than 85%. BRCA mutation is the most common or most popular of these. And in these patients, as well as patients above the 20% cutoff for that high risk stratification, we would recommend screening, supplemental screening with breast MRI. Breast MRI is the most sensitive imaging modality that we have in our entire arsenal of imaging. It's a time-intensive and resource-intensive exam, so we only plug patients who are at the highest risk into screening on an annual basis. So that's reserved for high-risk patients as a result of this genetic screening. And you may ask about the intermediate risk, that 15 to 20%. There is data that supports screening with MRI in those patients as well, but it's not a hard and fast recommendation. But data does show a benefit in those women for supplemental screening with breast MRI.
I'm going to ask another question. Should a new finding of amorphous calcification in a linear pattern be biopsied, or is it a common recommendation to wait 6 months? No family history of breast cancer, no palpable mass, except for a 40-year-old palpable fibroma on same breast.
So there were 3 things that were mentioned in that description that would be a trigger. 2 was amorphous, or the shape of those calcifications, and then the orientation of those calcifications are linear. All 3 of those would be essentially triggers for a biopsy recommendation. If this patient has had a mammogram previously and there were no calcifications there on the prior mammogram, we scrutinize new calcifications very closely. Amorphous calcifications also have kind of a 28% risk in the new setting for being disease. So that's beyond our threshold for following. Our threshold for following happens to be 2%. So that's another trigger for a biopsy recommendation. And finally, the linear distribution of these calcifications suggests that they may be within the ducts of the breast or a segment of the breast, which is a morphology or distribution that's also suggestive of disease. So a biopsy would be recommended in this case. Not that it is definitively disease, because that percentage that I threw out there was in mid-20s. So the majority of these biopsies may ultimately result in a benign pathology, but it should be biopsied nonetheless.
Let's see. The next question I have is, can you explain, I don't know who wants to take this, but can you explain more about breast density, what it is, how do I know if I have dense breasts, and how it relates to breast cancer?
So breast density is a feature that we can assess on mammography. It's essentially the ratio of the 2 normal anatomic elements of the breast, and those 2 elements are fat and fibroglandular tissue. When we look at a mammogram, fat looks black on an X-ray, while fibroglandular tissue looks white. And breast density is simply a measure of the ratio or the proportion of white to black, or fibroglandular tissue to fat. Roughly half of the population has dense breast tissue, and the other half has less dense breast tissue. And it's roughly around the cutoff of 50%. So 50% white to black is about the cutoff of dense breast to less dense breast. And that's essentially a ratio of fibroglandular tissue to fat within the breast. Now, I'd mentioned risk factors earlier for developing the disease, and I just want to reiterate that these risk factors are truly multifactorial. Breast density is one such risk factor. If you look at the population from a bird's eye or global scale, and you looked at people with dense breast tissue versus those without, there's a slightly increased risk of developing the disease in that population with dense breast tissue. It's ever so slight. I wouldn't be ringing alarm bells if you find out that your breasts are dense. As I said, half the population does have it, but if you look at that half of the population compared to less dense breast tissue, the dense breast tissue has a slightly increased risk of developing the disease compared to less dense.
Okay. Another question I have is, if I test positive for a genetic mutation, or if I'm high risk, are there steps I can take to lower my risk?
Yeah, I can take this one. So it depends on the risk. The one that most people, for genetic mutation, the one that most people know about is BRCA. Right, I call it the Angelina Jolie gene, who sort of made it famous a few years back when she went public about her bilateral mastectomies. So the risk in a BRCA patient could be upwards of 80%. And so the easiest, quote unquote, easiest thing to do is a prophylactic mastectomy, right? Removing the breast decreases your risk of breast cancer. Now that's not even 100%. Breast surgeons do our best. We're human though, and the breast isn't color coded and tells us which, cell is breast and which cell is fat. So there's always a chance you could still develop a breast cancer, even with a risk reducing mastectomy. For that population, we also often recommend removing the ovaries, usually in 40, 45. Removing the ovaries can reduce the risk of a breast cancer, even when the breasts are intact. There are other things like chemo prevention. Sounds super scary, but it's a hormone blocking pill, right? We talked about how hormones could influence breast cancer. A lot of the breast cancers are hormonally driven, and so blocking your estrogen could potentially decrease your risk. And then lifestyle modifications, again, quote unquote, easy things, decreasing body fat, right? We talked about how fat could potentially influence hormones. I always say decreasing alcohol, staying active, decreasing processed foods, all sort of healthy lifestyle modifications. Anything else my colleagues want to add to that list?
Okay, well, I have another question, which is, if breast cancer is found, how quickly do I need to make a decision about treatment?
That's a hard question. I think it depends on what kind of cancer, right? There are different breast cancers. The one that most people know about are the slow growing hormone positive. Then we have more aggressive ones that may need chemotherapy. And so I think it really depends on the cancer itself. And then I always say, you have to make the right decision for your body. So I never push a patient to make a decision. Now, if you're waiting 2, 3, 4, 5, 6 weeks and still haven't made a decision, maybe we should act on it. But I think most patients need to come to a decision in their own terms. It's their body, it's their choice, especially when it comes to a surgical decision. But the slower growing ones, you have a little bit more of a lead time than the more aggressive ones that may need upfront chemotherapy.
Okay. I have another question. Do I need to proactively ask my provider for genetic testing and bring the results in for my imaging?
Well, I can talk a little bit about, if it's okay, Dr. McKillop, about the program we have at BreastLink in Tarzana, where we run sort of your risk assessment here, and if eligible, we'll do testing on site. So that is one option, and I think it's at other RadNet facilities as well. I think if you do think you're high risk, I don't think it's wrong to ask your primary doctor or your OB-GYN for referral either to a breast specialist or to a genetic counselor. Genetic testing is fairly easy these days. It's a blood draw or it's a saliva kit. I don't see there's a huge downside. You can't get fired from a job. You can't lose health insurance if you're genetically positive. You could potentially lose the ability to get life insurance if you don't already have it, but they can't take it away if you already have it. I think the benefit of genetic testing, not only from a breast cancer risk, is we test for all sorts of genes. So we may be able to determine, do you need increased colon screening? Do you need increased ovarian screening? Do you need pancreatic screening? Really tailors your preventative care.
Okay. Do you know, are there clinical trials for people at high risk?
There are. There's one that we were looking at Cedars. I'm not sure if it's quite open yet, but it's looking at certain NSAIDs in high-risk patients. So yeah, there's clinical trials for all sorts of things. And you can usually just Google it to see what's around nearest you.
There's a website for clinicaltrials.gov, I think.
Yep.
Yeah, so definitely look into that. That's interesting. Okay, let's see if we have anything else. A lot of great questions. Okay, and there was a question. So testing positive for a genetic mutation does not affect you negatively in terms of insurance or employment or in any way like that.
Correct. There was a law, and the genetic counselors are probably the better one to ask about this, but yeah, you cannot be fired from a job. You're protected. You cannot lose health insurance. Like I said, the only thing that you could potentially have an issue with is life insurance if you don't already have it. But if you have life insurance, they can't take it away.
Right. What percentage of breast cancers are linked to genetic mutations?
I think it's like 10 to 15%. Most of them are actually sporadic, meaning we don't know what caused them.
Right. And if you had tested for, if you had done genetic testing in the past and tested negative, and let's say you've had breast cancer or you have a strong family history, would you recommend talking to a genetic counselor again or retesting?
That's a great question. Yeah, the amount of genes that we have now that we know about is definitely more and different than we knew about 10, 15, 20 years ago. So, if you were tested in the past and it was a BRCA specific test, I would definitely recommend talking with a genetic counselor to see if there's any updated panel testing available for you.
Okay. Okay. Another question just came in. Can you discuss sleep, too much or too little, as risk factors for breast cancer? I see online that too little sleep will increase it. And I see a study that says too much sleep can significantly increase the risk of estrogen receptive breast cancer. That one.
I don't know about that study, so I'll have to look that up. But I'm sure there are, like Dr. McCullough said, it's very multifactorial. Stress potentially plays a role, right? Not sleeping enough because of stress. I'm not sure. Anyone else have any input on sleep-related cancers?
I also don't know the answer to that, but as Dr. DeStefano reminded us, it is a multifactorial thing, and sleep, as simple as it may seem, it is a very complex thing. It has impact on your blood sugar levels. Certain steroids are released at cyclical and along with your circadian rhythm. So I wouldn't doubt that there is some correlation, between sleep and, ultimately cancers of some sort related to this, but I'm not familiar with the data or the studies that look into this.
And would you say that, if someone has some kind of predisposition, another factor can increase their risk as opposed to someone else who doesn't have some kind of predisposition? Something like sleep can increase someone's risk as opposed to someone else.
Oh, if I understand what you're saying, are there confounding variables? Like, is this person stressed out on a daily basis at work, and that stress is really the thing that's contributing to their risk, and what's associated with their stress is a lack of sleep? Yes, this is an association, but not necessarily a causal thing, if I understand your question.
Well, I mean, if somebody, has some kind of predisposition for breast cancer anyway, that maybe they don't know about, or, and then lack of sleep is just going to enhance that likelihood that they're going to get breast cancer, whereas somebody who may not already have some sort of predisposition.
Oh yeah, absolutely. I think we're all existing in some, form of homeostasis or equilibrium, and it may just take one small thing to tip us over the edge in terms of triggering the onset or the etiology of a disease of some sort. So yes, if someone is predisposed, some of these genetic mutations, for instance, have to do with cell or genetic repair mechanisms. Some human cells are just not capable of repairing the errors that are a natural consequence of DNA replication. So if you increase the turnover of cells in those patients, then yes, a slight trigger of that turnover may manifest that predisposition, and that ultimately manifests as breast cancer. So yes, I think we are all existing in kind of like a delicate equilibrium that can easily be tipped by environmental or, personal factors or individual factors, yes.
And if you're interested in that study, David did put it in the chat. There's a link to it if you want to check it out about sleep. So thank you, David. Okay. And well, let's see, if we don't have any more questions, then we can go ahead and wrap it up. And if you decide that you have another question that you didn't get to ask, you can always email it to concierge@breastlink.com. And we'd like to thank our presenters for this fascinating and interesting presentation. And thank you to Dr. DeStefano for joining us and for all of your valuable input. And thank you to BreastLink for hosting this special event. And if you would like any more information about any of these topics or about our locations or services, please visit www.breastlink.com. And thank you all for joining us today.